Welcome to Healthcare Rounds, everybody. I'm super excited this week to have Trafford Crump, Ph.D. Not an unfamiliar person to the podcast. He is a veteran, a champ with Healthcare Rounds, and one of my favorite people, and certainly one of my favorite people to argue health policy, music, I don't know, sports, whatever other stuff that we tend to find disagreement about. So without further ado, Trafford, why don't you give folks a little bit of background on yourself, and then we're going to get into patient-reported outcomes.
Sure. Yeah, thanks, John. Thanks for having me. I'm an associate professor at the Faculty of Medicine and Dentistry at McGill University in the Department of Surgery. I'm also the Jarislowsky Foundation Chair in Thoracic Surgical Outcomes.
That's pretty impressive. Who'd you have to pay off to get those titles? That's the question. Well, for further context, Trafford and I go back to our Dartmouth days, where we became roommates and partners in crime, not literally, but figuratively. And I thought we'd start off by we need to get some definitions out of the way, because when you hear the term patient-reported outcomes, it's sort of like, oh, I know what that is, because it's just what it says that it is, patient-reported outcomes. But if you would, considering our audience, give a little bit more meat around the bone with that definition, and then also maybe contextualize it in like sort of the broader term of real-world evidence, which I know more people will be familiar with what that is and what that means.
Sure. Yeah. Well, to start with some definitions. Patient-reported outcomes are those surveys that we hand to patients. Hopefully, they've been validated and the psychometrics have been established. But they are intended to ask questions about patients' symptom severity, their functional status, and most importantly, their quality of life. Typically they're used a lot. Typically they're used in clinical trials. I mean, that's kind of where they date back to in the sort of the early to mid 90s. And since then, they've been more widely adopted by clinicians and health systems administrators to try and measure some form of quality. As you know, we've tried to push systems to be more patient-centric, whatever that means to you.
How do patient-reported outcomes not be patient-centric?
No. Hey, I believe they are, but everybody's got a different definition of what patient-centric is. So
yeah, I hear you. Okay, that's fair.
Yeah, and in terms of real-world evidence, I mean, I think it doesn't get any more real-world than this, right? Asking patients directly about how they feel, what symptoms are bothering them, and how those impact their quality of life and their ability to get through their daily activities. So there are a whole bunch of different types of patient-reported outcomes. There are ones that reflect just on general or generic health, and those are applicable to anyone, regardless of what ails them. And then there are condition-specific ones, which are more obviously more specific to the condition or the organ system or the treatment intent, and are more sensitive to changes in symptoms or functionality around those. So they're really intended only for patients with those conditions.
So the typical, I think of like the ACO scorecards in the hospital, HCAHPS and all the other stuff that comes out of CMS. The segment on those, which is, did you get to see a doctor? promptly, things that are more about satisfaction, that's a component of PROs, right? Or that's one type. But what you're saying is when you start getting into the more condition specific, or how are you feeling specifically to, I don't know, have you been dizzy, or are you getting any other adverse events? Are you sleeping well? Things that might be associated with that condition, those are the ones that are probably more interesting, I guess, for us to focus on today, right? The ones that potentially could move the needle.
Yeah, and I don't want to get too nerdy for you here.
Please. Oh man. I am nerd cubed, man.
But we should distinguish between, patient-reported outcomes and then patient-reported experience measures, or satisfaction scores. And I think that might be what you're alluding to.
Yeah.
PREMs, patient-reported experience measures, satisfaction surveys, like those aren't patient-reported outcomes. Those aren't PROs. They carry a different conceptual framework. And I always chastise my students when they start to blend the two, because they're two completely different things. And yeah, we funding or health systems and certainly some funding mechanisms have tended to rely more on the experience satisfaction side versus the outcome side, simply because it's easier, right? Like,
right.
It's easier to kind of conceptualize, understand. We've gone to the hospital and we've given it a 4 stars out of 5, or a semi-happy smiley face out of a range of smiley faces. Those real technical measures of satisfaction.
But I mean, to be fair, the triple aim or the quadruple aim or the quintuple aim.
Have we gone to sextuplet on that aim yet?
Not yet.
It keeps on, every time somebody brings it up, it always bumps up there's another aim added that I'm not too sure.
Well, and I'm going to get a lot of flack for this, but I read fairly recently, I read something from John Berwick, who not only points out, okay, I didn't just invent this triple aim thing. There were some other people with me, and I love getting the credit for it, which is nice. But then also kind of lamenting the, kind of what's happened over the years, with the quadruple aim, and then, with,
keep going, man.
Joy in work, and then health equity being sort of like the fifth arm of that. Because the whole point, let's go back to school. The whole point was like this mindset of you can't, well, let me put it differently. The thought that if you spent more, you got better care. And this notion that there would be a trade-off, that you could actually improve the health of populations, improve quality, and, these things at the same time, was a different way of thinking. Right? I mean, that was the whole point. Yeah. And was like, hey, we can do these things together. There's always this trade-off, right? But actually we can make things better for populations. We can improve their happiness and satisfaction and all those things, and reduce costs at the same time. And so I think what I was referring to in this editorial or whatever it was that I dug up was just saying it kind of defeats the purpose if we keep adding on, yes, then it just becomes a list of things that we want to accomplish, and we want to do all these things. And the sextuple aim, I don't know. But in any event,
I like how many things can we aim at, right? Where before it just becomes the shotgun aim. Like we're just gonna scattershot this thing, and try and whatever we hit, hopefully it's going to be something relevant.
Well, I'm working on a project right now, and several people, because in the outline for this we'll call it a paper, in the outline referring to the triple aim, several people actually even around here at Darwin have said that's kind of old school, right? Triple aim. Like you're going to be, somebody even said you're going to be coming across as not being up with the times if you talk about the triple aim. And I was like, okay,
sure.
all right, well, I don't know what Don Berwick would say about that, but probably he might agree with me. But anyway, my point that I was making was, there is an element of that triple aim that is really getting after the patient experience, right? But what you're talking about is really more about tangible outcomes from the patient perspective and things that can be measured, and use the word, I don't know, reliable or valid, or maybe use both of them. But
psychometric, John.
Psychometric. Yes. Psychometric. And just to show what a nerd I am, in preparation for our conversation today, I was in Google Scholar and I was literally reading about psychometric properties of these variables that are used in PROs. So don't tell me I didn't do my homework, Trafford.
I'd never accuse you of that. I will accuse you of maybe not interpreting the triple aim correctly, because I see pros fitting squarely within, the population health. We need to improve population health, and how are we going to measure that?
Oh, I agree. Maybe I didn't say it right. I agree. I'm saying it's another component of it.
Yeah, and so I think and there again, there's a good example of how satisfaction is distinguished from health, and why I dislike the mixture of patient-reported experience and patient-reported outcomes, because they're two different things. They're two different aims, if you will.
Right. So are there, maybe I'm jumping ahead here, but are there specific disease areas or medical specialties or, places where PROs or pros, do you say pros if you're really cool? Is that the hip way to say it, pros?
You're allowed to say that.
Okay. So are there areas, like I saw stuff in orthopedics, I saw some things in kidney disease, but what has been your experience? Because I know you've done a lot of research in this area.
Yeah, so the pros definitely lend themselves well to care or interventions where the episode is clearly defined and is easily identified. So things like, say, elective or planned surgery. That's sort of a classic event where patient gets referred to a surgeon, and the surgeon undoubtedly recommends surgery. Patient goes under the knife, comes out, has rehab, things are done. So we can kind of measure on a longitudinal basis there, over time, before and after the surgery, and we can see, what, if any, health gains the patient receives as a result of the surgery. More complex is things like oncology. So in my world, for example, esophageal cancer, where a patient, may or may not demonstrate symptoms, and then gets scoped, diagnosed, and then some may go in for adjuvant therapy, and that adjuvant therapy might be chemo, it might be radiation, might be both. And then there may be a surgery, right, to remove the cancer, and then some rehab and a long sort of follow-up time to make sure they're clear. And what do you do if there's any sort of metastatic cancer or anything of that? So the edges of the episode are a little fuzzier, a little harder to measure. And then harder still is chronic care, because there isn't necessarily a single intervention there that allows us to kind of create a window around it to define the episode. And there, you're just kind of monitoring, I guess, symptom severity over time, not necessarily with a specific intervention in mind, but more to understand, I guess, disease progression, symptom progression, and sort of how those are going to be managed by not just one care provider, but oftentimes, multiple care providers, multiple locations. And this is the other thing. I mean, going back to the complexity of it, trying to coordinate measuring the same pros across different providers, especially if they're in different locations or different settings, can be really difficult because some providers may be interested in different types of surveys. Some might be institutionally bound to collect some versus others. Others may just have like ones that they prefer, either because that's the one they've always used or that's the one they were trained on. And others still may think they're just a waste of time, so they don't collect them. So trying to coordinate that across different settings and different providers gets infinitely more complex as you start adding to that.
Well, you answered one of my questions, which is, what are some of the barriers? But I'm still kind of stuck on the so what. And you gave two very good examples. One that I can definitely identify with after my shoulder surgery, and the measurement that's going on at the PT. The guy who does my PT is very into the numbers and publishes stuff himself. To esophageal cancer, and the so what that I'm looking for is I'm going to make an assumption that at least a good chunk of our listeners come from sort of the life sciences, biopharma, that world, and another good chunk come from the delivery world, health systems. I'm sure there's some consultants in there as well, but people who are making decisions about how to improve the quality of care. And so what is the so what around pros? Considering those audiences, the actual delivery, and then on the R&D side for treatments.
Yeah, so let's take the delivery side first. I think the so what is, what is the impact of the care that we're actually delivering? And if we look at, say, the classic definition of value-based care that Porter put out, 15 years ago or something. Again, another concept that's been totally mutilated through various iterations. The definition is improvements is cost over improvements in patients' health. So quite clearly, PROS plays a very critical role in defining value-based care. And I mean, aren't all providers now driving to provide patient-centered, value-based care?
Yep.
I'm sure we'll have some more buzzwords. I'm sure some more buzzwords will come up this pod, and we'll be able to add that to that list. But I guarantee you, if you go on to 10 hospital websites, 9 of them will have value-based patient-centered care on there.
Yep. Right place, right care, right time.
Oh God, yes, that's another one. Love it.
Yeah.
So anyway, so that's, I guess, the so what.
But in defense, if we were to go back in our time machine 10 years ago, 15 years ago, whatever, that wouldn't have been the case, right? I mean, yeah.
No, I mean,
the idea of patient satisfaction has been around forever, right? But
sure,
at least it's a reflection of a change in the, you ready? Zeitgeist.
Yeah,
among physicians.
Yeah, for sure. But when Porter came out with that, he directly linked outcomes, specifically health outcomes, to costs. And said if we're not improving outcomes relative to their costs, we shouldn't be doing it. And you'd be surprised at just how often care is not improving outcomes. And so, that I think that leads to a broader philosophical question about what we're trying to achieve with healthcare. But to get back to your question, let's talk about R&D now. It's important that you demonstrate how a new drug, a new piece of technology or a device is improving over the status quo or what
Sure.
has come before it. And so if you can demonstrate that your new drug reduces symptom severity or improves patients' quality of life, even if it's sooner than what the status quo does, then I think you've got reason to argue that your new drug, your new intervention, whatever, is superior.
But wait a minute. Is quality of life a pro or is it a prem?
Yeah, no. Quality of life is a pro. It's not all instruments never necessarily measure quality of life, but a lot of them do. And quality of life again has got a lot of different definitions, but essentially what we're looking at is the impact that your health is having on things that matter to you in terms of your ability to function physically, mentally, socially. Yeah, and so that's very much a pro. And so so there is the importance of patient reported outcomes as part of clinical trials, as part of measuring the difference of a trial or a test intervention versus status quo, and then also in sort of the follow-up post-market evaluation, where maybe the new intervention, the new drug is improving things that it was never intended to do, that as sort of secondary benefits, and all of a sudden it opens up new avenues for potential applications.
Obvious example, the GLP-1s, right?
Yeah, exactly.
So in that circumstance, let's dive in with your example. Let's say that I'm big pharma. I've got a new drug or maybe a new indication for an existing drug for esophageal cancer. How would I be thinking about pros in both? So in either circumstance, I guess, would be, how would I think about that in the clinical trial setting? So let's say I'm in phase 3, or how would I incorporate that into the post-market surveillance where I'm gathering new data on the outcomes for my drug for esophageal cancer? How would I think about that?
Yeah, I think there are a couple of things to think about. One is, what are you looking to improve upon, and identifying sort of the outcomes that you feel are important or ones that your new drug are intended to improve, and then pick an instrument that sort of addresses that. So if you're talking esophageal cancer, you may be interested in improving swallowity. Swallowity.
It's a new word.
I love it. Swallowing.
Right.
Or like nutritional uptake. And so you may want to pick an instrument that addresses, one's ability to swallow, one's ability to eat. Now, closely related to that, because often when we're eating, we might be going out for dinner or lunch, we might be eating with family or friends. So there might be a whole social aspect to that you may want to measure, and this kind of goes back to the quality of life issue, whereas before the drug, you were less inclined to go out for dinner, because you didn't want to sit there and, not eat, or, spend an hour trying to eat a simple meal. And now that you've had this new drug and it's improved, your ability to swallow, all of a sudden your social life has kicked back into gear, and you're reporting improvements there. So, you want to try to be specific with the outcome, but you also maybe want to consider the broader context and try to capture that, because those are all positive, right? And those reflect well on a new drug. And then now I say that with sort of one condition, and that is, you don't want to overburden patients. Some of these questionnaires, like one, going back to our esophageal cancer example, the ones that are prevalent, most commonly used in that condition, are like 30, 40, 50 questions. Nobody's really going to want to be filling that out on a regular basis, particularly if they're doing it, with a bunch of other things, a bunch of other tests and that kind of thing that they have to do as part of the trial. So you want to be cognizant of the response burden that you're placing on patients. Go ahead.
I was just going to say, I'm playing devil's advocate, I think.
Not you, John. Not you.
I don't know if I am or not, but if my primary outcome is survival, let's say I'm using 5-year survival rates or whatever it is, if that's my primary outcome, why do I care about, in my clinical trials, why do I care about those other variables?
Yeah, I think there are still a lot of diseases that where survival is primary outcome, but there are a lot of diseases where we've kind of solved the survival issue. Now it's a matter of, like, what kind of quality of life are you going to have with the years that you've been that you've kind of gained back by taking the drugs. And so that's where that's where tracking the quality of life, symptom severity, can help improve not only how your drug looks, but how you might inform patients about what to expect when they take the drug. So setting expectations, as you know, is always a critical part of healthcare, and making sure that patients have realistically thought through the options that are before them, and are making informed decisions about the kind of care that they want to receive, particularly if it's a question of surviving, and surviving with a certain amount of quality of life.
What do you say to those other devil's advocates, or maybe the naysayers that say, well, it's all subjective, because we're just interested in hard outcomes that we can measure through, PET scans and blood work and everything else. What do you say to those people where you say, well, this is just all subjective?
Yeah, it is subjective, right? But isn't that what healthcare is? Like isn't it trying to deliver care that people feel better about themselves? That they're able to kind of get through life. They're able to play outside with their kids, or go out for dinner with friends and family. They're not sitting in chronic pain or with severe depression. Of course, these are subjective measures, but then it's not a question of qualitative versus quantitative outcomes. It's a question of which outcomes matter most to patients.
Right.
And
well said.
It's not the survival may be important, but survival with better quality of life, may be as important or more important. So these aren't meant to be exclusive. Like, it's no one's saying that you can't record patient-reported outcomes in addition to clinical metrics, in addition to observer outcomes. I'm just suggesting that they should be part of your suite of outcomes that you're measuring?
So one of the things, this is going to show my lack of research prior to this interview.
What do you mean? You just said you were on Google Scholar. You read an article.
I was, but I spent about half an hour. I didn't spend.
You read psychometrics, something about psychometrics.
Because I think psychometrics is cool. I do because I'm a nerd. But one of the things I noticed was that there was a lot of. You mentioned the late 90s, as kind of a little bit of uptake in this area. And then it looked like late 2000s, 2011, 2013, 2014, there was a lot of conceptual work and review work that was done in this area. But I didn't see a lot of really recent direct application, papers on here's where we use this set of pros. Sorry, got to get my lingo down. Here's where I applied this in, esophageal cancer, after spine surgery, after hip replacement, whatever. I didn't see a lot on that. So what is the state from your perspective? Because I know you're involved in this research. What's the state of the actual use of pros today in the research setting?
In the research setting or in the delivery setting? Yeah. What setting are we talking about?
I think there's like 3 or 4 questions in there. So I'm curious on the research side, but I'm also curious on the clinical, like in the patient care side and the actual application.
Yeah.
What's the state of pros today?
I think on the research side, we kind of have it figured out. But it's as our mutual friend Paul Woods like to say, sort of the land of 1,000 pilot projects, right?
Right.
So, we have research that demonstrates, the advantages of collecting patient-reported outcomes, how you do it, sort of the, what are the barriers versus what are the facilitators. There's no real mystery left in that. There might be some smaller challenges like, trying to collect e-pros with the homeless population or, people who don't have email addresses or something like that. But for the most part, I think we know that again, from a research perspective, that collecting patient-reported outcomes offers a valuable and important insight. Now, on the delivery side and on the real-world side, it's much more challenging for a variety of reasons, and I think part of that is just you can kind of group them into maybe 2 or 3 or 4 buckets here. One is you've got the whole infrastructure. How are we going to do this? People are trying to implement it through patient portals. Others are using, apps on your phone. Others still are, connecting them to registries or databases. But all of that, regardless of the delivery method, they all require budgets and people, and that's hard to. It requires investments. And then the other bucket is, as I mentioned earlier, this is particularly true for say health systems or health networks where you have multiple providers in multiple settings. You've got to come to some kind of agreement on what is going to be the core set that we identify, that we use with patients with specific conditions. And you got to do that with every different condition, right? So it becomes far more of a challenge, far more of an undertaking. And then further to that, you got to identify when are we going to measure it? So you got to coordinate across all these different providers and settings when the episode of care, as I previously discussed, and when you want to measure. And then sort of the third bucket is clinician and patient engagement, which is a critical point or critical part to all of this. it's like your patients want to have to fill this out in order for you to get the information.
Sure.
And just because you hand them a survey doesn't necessarily mean they're going to fill it out. Or they may fill it out like 1 or 2 times. And by the 3rd time that you've handed them this questionnaire of 50 questions, they're like, that's to you, man. I'm not go pound sand. And that's because, what they need to see, what patients need to see is that these pros are actually being used in their specific care. And I think there is an opportunity to help personalize medicine more by incorporating pros. Especially if you're using them at the point of care to help inform, clinical decision making. But you have to make it clear that the questionnaires these patients are being asked to fill out are what is being used to do that. That is that's providing the foundation for more tailored healthcare.
So in the one example with my shoulder, it might be that I am aware that my treatment plan is being altered throughout the course of my treatment in response to these pros. In the esophageal cancer example, it is, in some ways, it may be a little more obvious in the sense that based on the way that you're reporting, let's say you're in a clinical trial and you're on, I could just think of my father-in-law right now, who is, battling lung cancer and is going through chemo and has an immunotherapy, and he's in a clinical trial for a phase 3 drug. So if through part of that, as you're reporting what's going on, maybe you get switched to another drug, maybe you get switched to more of the drug, more frequency, or other things. So, but as a patient, I am aware that I fill this out. It's kind of a pain, but if I do, then I might get better treatment. I might feel better. I might whatever, because it's in response. So I think, is that about right? Does that sound about?
Yeah. And it allows you as a practitioner to alter, the management plan. So if patients are having a hard time swallowing, perhaps they get recommended to go on a liquid diet, or soft food only, that kind of thing.
But really, more of the benefit is if you have these established metrics that you're using and they're consistent within the organization, then it takes some of the guesswork. It's almost like the pros become part of, whatever your algorithm is or whatever your pathway is.
Yeah, you just touched on something that I think is another critical barrier to implementing pros, both in a trial and in a real world setting. And that is, that very rarely or in very few conditions that I've seen are they linked to specific clinical guidelines. So, what do we do if your pain score, hits 7 out of 10? Right? What do we do if you're unable to sleep at night because you've got to get up and pee? That's, I think, where the next frontier of this work, if you believe that pros are an important part of healthcare, and I think there's a big debate to be had there. They need to be incorporated into clinical guidelines, evidence-based, obviously, that let clinicians that facilitate clinical decision making. That let them know that if your patient is struggling here, these are your options. And so without that incorporation, it's really just going on sort of clinician experience. And I think this is where there's some maybe hesitation on the part of physicians to adopt patient-reported outcomes or to incorporate it into their practice, because they really don't know what to do with the responses. They're like, okay, yeah, I see you're struggling with swallowing here. Let's try A, B, or C. But that A, B, or C isn't really based on any evidence. It's just based on their experience.
But isn't that the goal? Or maybe we're saying the same thing. The goal of having these outcomes is to have that better decision making. But
yeah. I think what we need now is, as I say, is to develop it, is to incorporate them into the clinical decision making and sort of the decision tree. Like if it hits 7, you go here, and here's the evidence to support it. And we just don't really have that now.
Well, I can see sort of I can understand the pharma side of it much easier in the sense that, whether it's in a clinical trial or post-marketing surveillance, I think of it in the hands of a marketer that wants to be able to capitalize on certain pros, let's say, or things that they've studied to be able to compare their product to another product and say, this is better for the following reason. I mean, obviously overly simplifying that scenario, but on the health system side, is there evidence? Have you been able to document, or are there papers out there that you've seen that really do show that that the application of pros not only leads to better outcomes, but back to your value-based care argument and the Porter model, this Porter model, that you're actually reducing costs, or you're having an impact on the health system's finances because the total cost of care has gone down. I mean, are you seeing any kind of evidence for that, or is there a body of work around that? Because honestly, Trafford, I think the show me the money side is what is going to get, at least in the U.S., the health systems to really start paying attention to it. The experience stuff and all of that, of course, that's important. But so what have you seen in that area?
Yeah, and to answer your question directly, we really haven't seen that link to value-based care where if you measure patient-reported outcomes, you will see a precipitous drop in the cost of care by X amount. And the reason for that is simply because we as a system, we as a society are reluctant to cut care that isn't of value, right? That doesn't demonstrate improvement in outcomes, and
so-called low-value services or low-value.
Yeah. Whenever you try to propose to cut low-value, or as going back to the Dartmouth lexicon, the Wenbergian lexicon, unwarranted variations in care, you're immediately tarred and feathered as wanting to ration care, as if that's some sort of negative, or that you want to you're getting in between, you're making the decisions between the physician and the patient.
Death
and so
panels.
Yeah, exactly. So if you were going to commit to value-based care, it also means committing to cutting out all the stuff that doesn't work, or identifying the patient populations where a certain intervention, a certain drug just isn't appropriate or isn't necessary. And good luck selling that.
Yeah, well, that's a whole other can of worms, right? I mean, there's a lot of low value services that are being performed out there that obviously they're being performed because they make money. They're revenue generating. And so it's hard to wean yourself. I mean, important point, right? If you're all in on value-based care, you've got to be willing to look at those places, maybe that are even revenue generating for your health system, that really just have no business. You have no business providing that service or, doing as much of it as you do. But then, as you say, maybe you get labeled as a cutter or one of, you're just ready to ration care. So,
and I think that just to, I guess, maybe belabor that point a bit. Who wants to measure patient outcomes on an intervention that we know has no benefit to the patient, right?
Right. No, that's true. So, well, we could keep talking about this and all other things healthcare, but I'd rather have you come back and talk more about healthcare in general. Any other final thoughts of, I feel like over the last 45 minutes or so, we've done a good job kind of talking about the problems and identifying at least what we're talking about when it comes to pros, what they are and what they're not. What's the cliffhanger? What do you want to leave people with to be thinking about pros if you're a clinical research person in one of these institutions, or if you're a financial manager and you're hearing this for the first time? Like, what's the takeaway that you want people to have, and just thinking about pros for the future and where the opportunities lie?
Yeah, I think it's that if you're going to commit to this, if you're interested in patient-reported outcome measures, and you want to commit your institution or your program to it, have an objective behind it, like a measurable objective, and do it with some intention. This is not something that should be taken on simply because it's the flavor of the month, or you're trying to back the buzzwords in your mission statement. Have a plan of how you're going to use the data, and how you see that pushing either your company forward or your services forward. And I think that will lead you down a more important path than if you just kind of say, we're going to hand out this survey and expect every patient to fill it out, and we'll figure out what we do with it later. Everybody's going to have a different sort of motivation behind why they want to take it on and incorporate it. But at least having that motivation be clearly defined will give meaning to the exercise.
Well, for me, what I'm still thinking about is just remembering the humanity in all this, not to sound so corny, but we're talking about healthcare, we're talking about people, we're talking about the patient's perspective and all of these things. It's easy to kind of say that those things are important, but it's easy to just kind of get wrapped up in the data and just spreadsheets and and not be thinking about that. If pros, for example, can not only lead to better outcomes by using them, but also a better experience as well, and humanizes healthcare. And a little bit of a teaser, I've got one coming up where we're going to be talking about this exact issue. I have a colleague of mine with AbbVie that I'm hoping to have on here in the next month or so. We're going to be talking about this, and that's I guess I haven't said it as well as you have, but that's for me one of the biggest takeaways is to remember what we're dealing with here in healthcare, which is people.
Yeah, and it is another data point, but there's meaning behind it, right? And it's more than just in order for it to have value. I think you have to go beyond it being just another column in your spreadsheet, and to really incorporating it into the way that you deliver care.
Well said. Well, Trafford, thanks again.
No problem.
Look forward to having you come back. That'll do it for another episode of Healthcare Rounds. Don't forget, please rate, review, wherever you listen to your podcast, or if you're watching this on YouTube, make sure to subscribe and rate and review. I'm John Marchica, CEO Darwin Research Group, and thanks for listening. We'll see you next round.